Good morning, everyone, and welcome to our monthly International Colorectal Web Meeting. Today, so far, we have participants from Brazil, South Africa, Trinidad and Tobago, Nigeria, Saudi Arabia, Egypt, Pakistan, Mexico, and Kyrgyzstan. So if I didn't mention your country, please type in the chat and I will acknowledge at the end. I just see Sudan is also present, as well as India. So, much more, and Uganda. Can you write down here? So the first presenter, we don't know what happened, but unfortunately has not showed up. So I'm gonna try to present his case. Apologize, this is not my case. But it's supposedly a case of rectovestibular fistula with a normal anus. So Ray is going to advance the slide for me. This is a 6-week-old girl, otherwise healthy, that was born at 39 weeks of gestation. She was brought to the emergency room because she was crying while passing urine, and a urinary tract infection was suspected. Upon taking urine sample with an in and out catheter, the nurse noticed stool coming from what she thought was the vagina. There was no important family history. Next. So she was well, the abdomen was fine, well-developed buttocks, and there was a visible tiny opening in the vestibule. So we can go to the next. So the pre-op diagnosis was either a rectovaginal or a rectovestibular fistula with possible anorectal malformation. She underwent an examination under anesthesia and excision of this fistula tract. Post-op diagnosis, rectovestibular fistula with normal anus. Next. They said that the anus was slightly anterior, but within the sphincter complex, normal anal tone, anal size to Hager 12, no narrowing, and the perineal body 1 centimeter wide. So the presenters had the challenge between ligation of the fistula or excision of the fistula, rectal versus vestibular approach. So they decided to do excision of the fistula. They identified the tract with a lacrimal duct probe and completely excise the fistula and reconstruct the perineum. Next. The patient was seen in clinic. There is no sign of recurrence, and she is off any medical treatment. Next. Next. So this is a video just showing the anus that is normal. I don't know if the video will work. If not, it's fine. So it's a normal anus. Can move to the next. And here you can see the lacrimal duct probe going from the vestibule and opening in the anus. So this is a rectovestibular fistula with a normal anus. Next. So what they did was resecting this fistula around the lacrimal duct probe. Next. And then they reconstruct the perineal body. Next. So the questions, any questions or discussions? So I think whenever we have a fistula, it's very important that the tract, that the mucosal lining is resected. The only thing is resecting that without opening the perineal body, in my opinion, makes it harder. So what we do exactly what the presenters did. We pass the lacrimal duct probe, but then we open completely. So you can see the entire fistula tract. You can remove the mucosal lining separate the anterior rectal wall a little bit to have more tissue to reconstruct the rectal perineal, the perineal body. Do you want to comment?
This malformation falls into the category of complex defects. It's extremely unusual, but it happens. Everything is possible in medicine and surgery. And the goal of the operation, as Dr. Bishop just mentioned, is to remove all the mucosal tract between the rectum and the vagina, and be sure, try not to leave a suture of the rectum in front of a suture of vagina. For that, sometimes we have to mobilize a little bit the anterior rectal wall to be sure that you leave a normal rectal wall in front of a vaginal suture. And then congratulations to the authors, because we don't argue with success. They are telling us that the patient is doing well with no fistula, and that's what is important.
Any questions or comments from the audience before we move to our next case? Let me see if there is any question in the chat. There is one question asking, is a stoma needed?
If you are dealing with the patient in the first day of life, and the patient has not been eating, and you have experience in dealing with newborn tissues, then you can repair the malformation with no bowel preparation and no colostomy, because the meconium is sterile. Now, if the patient comes to you months or weeks later, it's already eating, the colon is colonized, in other words, it's full of bacteria and stool, then the patient needs a complete bowel. You have two options. One is to open a colostomy, then repair the malformation, and then close the colostomy. And the other option is to clean completely the colon, perfectly clean with Go-Lightly or any measures that you have at home, to be sure that what comes out from the anus is pure water and not stool. And at that point, you repair the malformation, put a central line, and give parenteral nutrition for 1 week, nothing by mouth. And now we know that there are many surgeons who try to save time, discharge the patient early. They are in a hurry, and they claim that you can do the operation without a colostomy, without antibiotics, without bowel preparation. And yes, you can do that. But I warn you, if is one catastrophic event, one dehiscence in a baby otherwise normal with normal sphincters, will be an unforgettable and very bad experience. And that's why we never had a dehiscence, and that's why we become so conservative.
Well, many questions. Question number one, is this a perineal canal or a perineal groove? No, it's not. A perineal groove is when you have a mucosal lining from the vagina to the anus, but the mucosal is at the skin level. It's very superficial. This is a fistula. It's deeper than the skin, so that's different. The other question, have you
said that about terminology? Before 1980, the terminology that dominated the area of anorectal malformations was created by Dr. Douglas Stephens. And he created many, many terms, including that anal canal that somebody mentioned. We consider that terminology not adequate. We prefer to have a more descriptive terminology. This is a patient that has a normal anus and has a communication between the anterior rectal wall and the posterior and the vestibule. So it's a rectovestibular fistula with normal anus. Yet by saying it that way, you don't get into the terminology problems. You are describing exactly the malformation.
The other question, have you seen this malformation presenting later? In the majority of the cases, it presents a little later when the patient has already fed. The mom starts seeing stool from what she thinks is coming from the vagina. Of course, the majority of patients that say that they are seeing stool in the vagina, they are normal babies. It's just that they poop and the stool go there. but in some cases we find. And we feel that the best way to diagnose is with an examination under anesthesia. It's very hard with a contrast study to try to make the diagnosis.
Then, yes, I have seen a patient that was born with a perineal fistula, very narrow orifice in the perineum, and the patient becomes severely abdominal distension. And the pediatricians never look at the bottom, because many times babies are born and nobody looks at the bottom and they are discharged with a malformation. So the pediatricians never look at the bottom, and the baby started having the abdominal distension and vomiting, and the pediatrician thought it was just gastroesophageal reflux. Eventually, the patient, the female patient, started passing stool through the vagina. So the rectum perforated into through the posterior vaginal wall because of the distension and the pressure. So that was an acquired rectovaginal fistula with a perineal fistula.
And the other question is this similar to an anorectal fistulotomy? Usually for those cases, they just open and let it heal on its own. That's not what we propose for this malformation. And the other question was if there is a value on laser ablation. I don't have experience with that. So, other question, do you regard such cases as more likely primary congenital malformation or acquired result of preceding inflammation? So those are theories. We don't know. We think it can be a result of an infection. The theory is that when it's presented at newborn, it's an acquired malformation. When it's presented a little later, it's a result of inflammation. But those are theories. Can it disappear? Very good question. Do you want to comment on that? If those fistulas can disappear?
There's no study that we cannot answer that question because nobody has a series of those patients.
No, but it's you had. So let me just say, because I learned that actually from Dr. Peña. We believe that there is some similarity in the fistula in ano with when the baby presents as a newborn. So you had two cases.
There's a very important differentiation. Fistula in ano that Dr. Bishop was referring to is a condition that happens in males and females that communicates one of the crypts of the anal canal with the skin outside in the perineum or the lateral or sometimes into the vagina. That's an acquired condition and results from an infection that goes from the crypt, the crypts of the anal canal. Because you take the baby under anesthesia, you pass a lacrimal probe through the orifice of the fistula and comes out into the crypt. That we are not discussing about that. That we have I had a publication about that. That condition does not require an operation. That condition should never be operated because all those cases heal spontaneously within 6 months. You just watch the patient, the parents get desperate, but don't operate, and the patients heal by themselves. Now, we are talking about congenital real fistula. That's completely different, unrelated with the pectinate line. That's another condition.
So now we're going to move to the second case that will be presented by Dr. Muhammad Maray from Egypt. So welcome.
Hello, Dr. Pena. Hello, Dr. Bishop. How are you? It's really nice to meet you again. Today we have this case. I believe I told you about it before. It's a posterior cloaca associated with tracheoesophageal fistula and congenital adrenal hyperplasia, as we believe. Can we start the presentation now?
Yes, go ahead.
Examination at first. This newborn presented to the NICU with difficulty of passing the nasogastric tube. So they called the pediatric surgery team to evaluate it for being a possible tracheal esophageal atresia with tracheoesophageal fistula. But after examining the patient's perineum, we found this, what we saw as an ambiguous genitalia. So the patient had a normal anus, normal looking anus, and this small phallus with an opening at the tip of the phallus, dripping just a drop of urine. However, when the baby was straining, the urine and the vaginal secretions were coming out from the anus. So we separated the anus and we found a small opening just anterior to the anus. After passing a small catheter inside it, it drained both urine and vaginal secretions. We found in literature this paper published by Dr. Pena, Dr. Bishop, and Dr. Mark Levitt, which we now know that this case is a posterior cloaca. And actually, in this case series, there are almost 29 cases, and our case is mostly similar to case number 29 in a way. So we already know that the cloacal anomalies are broad spectrum. So we will present this case in which a unique variant of the posterior cloaca spectrum. The neonatologist consulted the endocrinology team for what they thought is ambiguous genitalia, and they ordered labs in the form of 17 hydroxyprogesterone, ACTH, testosterone free and total levels, and androstenedione. So these were the laboratory results. So we can see that the testosterone level are slightly, or I don't know, they are higher than normal, a little bit. And the 17 hydroxyprogesterone is almost 12. And as they say, most of the cases with CH in the neonatal period are more than 10. More than 10 equals CH until proved otherwise. So they already started the medication because the patient had a tracheoesophageal fistula and she needed to be operated at once. We operated through right thoracotomy incision, and the patient discharged home, passing urine, stool normally through the same opening, and we delayed our operation till after 6 months. At 6 months, we did this genitogram by injecting the water-soluble contrast through the small opening in front of the anus. So we can see the vagina, the urinary bladder, and the vagina, wide vagina. However, this contrast is extravasation from the fallopian tube. So we did MRI, a non-contrast MRI of the pelvis, and we found that the patient had double uterus and double vagina. So this is cross section showing double vaginal openings. This is a very short video of the cystoscopy done, showing normal bladder with normal post-ureteric openings, and now we are inside the vagina, and this is the vaginal septum. Intraoperatively, we thought, as I mentioned, that this was a normal looking anus. It was really normal looking. However, after doing the electric stimulator, we found that it's slightly anteriorly displaced. So intraoperatively, we took multiple stitches. We started dissecting the urogenital sinus. This is the whole complex together. And now we are separating the urogenital sinus from the rectum. Well, surprisingly, during separating the urogenital sinus, we found this small channel, which we later knew that this is an accessory urethra. It was passing dripping urine, and it was catheterizable by a 5 French feeding tube. So we completed the urogenital sinus mobilization, and we did reconstruction of the perineal body and relocated the anus in the normal sphincter. And we started dissecting the foreskin around this small phallus, and we found out that it already has corpora, as we see, and this is the glands. And as I remember, Dr. Pena said most patients with cloaca that they look like they have ambiguous genitalia. When we examine this small phallus, we find out that it is just skin, no corpus tissue inside this phallus. However, this is not the case here, as we believe. So we dissected this phallus and reconstructed the labia minora using the prepucial skin. And this is the case after 1 week with slight edema. This is after 1 month, and this is after 3 months of follow-up. Right now, the patient is 2 years old and 2 months, and she is controlling her urine and controlling her stools with no back pressure on the kidneys, with normal looking vulva from outside, and almost normal looking introitus and catheterizable urethra. Thank you.
Well, congratulations for your case. And we repeat always, we don't argue with success. If indeed the patient has urinary control, if indeed has bowel control, which I doubt it. I'm sorry to say I doubt it. You have to wait until the patient is older than 3 years old. It's too beautiful to be true, because a case like this, first of all, I have questions about the diagnosis of intersex. I have questions just based on the laboratory studies. I would repeat those laboratory studies, because it doesn't look to me from the anatomic point of view like an intersex. So you have to see how the ovaries look like, how is there testicles, how the gonads are, and repeat those studies. And in a case like this, we do not mobilize the rectum. We do not dissect the rectum. We simply split it in the midline with the patient face down. And by doing that, we can mobilize the urogenital sinus to put it in the right place. That's the way I would do it. And I'm concerned about bowel and urinary control in this patient, but this patient simply had a posterior cloaca. And the question of intersex, I'm very skeptical, to tell you the truth. But we don't argue with success. If the patient is doing well, congratulations.
Okay,
yeah, unfortunately, the values are different from the reference values that we use in the United States. So I couldn't even really say, yes, it is indeed a case of differences in sexual development. But we have received, I told you, many cases that were diagnosed with disorders of sexual development. They were already on steroids, and when we repeated the study, we could stop because they were actually not the case. So I would just call the endocrinologist and say, hey, can we really check again to make sure if this diagnosis is true? Just because our values are different, so I could not say for sure.
Well, as
And
I
the,
yes, you already told me that in Mansoura, and I already called the endocrinologist, and they are reviewing their laboratory investigations, and we are waiting for them to confirm to us either it's really congenital adrenal hyperplasia or if they were mistaken from the beginning. So we are doing this right now. And regarding the patient's gonads, I didn't mention in the presentation, but we did laparoscopic exploration, and we found that the patient had normal looking uterus, normal looking fallopian tubes with both ovaries, normal looking, and no other gonads in the patient. I'm not saying that it has to be CH, and I'm not saying that she is really right now controlling, and we already waiting for the patient till she grows up to confirm the bowel control. But regarding from the history of the mother, that the patient can pass once or twice per day. She right now she tells her mother that she needs to defecate or go to the toilet to urinate. So that's what we have right now. But we still following up the patient.
Perfect. So we will wait for the follow-up from the endocrinologist, because I think everybody will be curious to know the final answer.
we look forward to see about the chromosomes of the patient and the endocrinologist diagnosis. What is the final diagnosis from the endocrinologist point of view? And if it is indeed adrenal hyperplasia, they have to follow up for a long time, and they have to decide whether it's a salt-losing adrenal hyperplasia or not salt-losing, because they require special management. I seriously question the diagnosis of intersex, and I seriously question the possibility of bowel control.
Well, Dr. Benya, what we have right now, this patient, we already did a chromosomal study, genetic study, and it was XX46XX. So we know that she is genotypically female, phenotypically female, and anatomically, when we did the laparoscopy, she is a female. So we are sure from that. Regarding the endocrinology point of view, the patient, as I mentioned, the patient has esophageal atresia with tracheoesophageal fistula, and we operated on the third day. During these 3 days in the NICU, the patient had hyperkalemia, hyponatremia. So the endocrinologist thought that this must be a salt-losing congenital adrenal hyperplasia. However, as they mentioned, to be 100% sure, they have to do enzymatic study to know if the 17 hydroxyprogesterone and 21 hydroxyprogesterone level is low or not, or a genetic study, not a chromosomal study, but genetic studies. And unfortunately, we don't have the genetic study available in Egypt. So we are still waiting for them to confirm to us, and I will keep you updated.
Perfect.
Good.
Thank you very much. Thank you for your presentation.
Thank you. Thank you for giving me this opportunity. Thank you.
I'm going to share my screen because I'm going to present the next case. So this was a 1-year-old female patient that was born with a rectoperineal fistula and absent vagina and uterus. So what information do you need to determine the type of reconstruction that you're going to offer? Chromosomes, hormone levels, sacral ratio, or I don't know. Everybody can vote.
Few more seconds here.
What's the information?
Rectoperineal with absent vagina and uterus. So majority answered correctly. What we need to know is how is the sacral ratio, meaning what's the prognosis for bowel control for this patient? Very good. So here you can see the sacrum of the patient. The patient has multiple hemivertebrae and a very short sacrum. So the sacral ratio, sorry, I cannot see, but if I remember correct, was 0.24. So we know that this patient will not have bowel control. She also has tetrachord. You can see that the conus go all the way down. No, just tetrachord. So this is the contrast enema, and I want to show you because this is very important for the reconstruction that we did. So here you can see that it goes here, then it comes down here, and then it goes there. So again, this goes here, then it comes down, goes up, and here. So it's a very redundant sigmoid and dilated. And here you can see the bladder with vesico-urethral reflux. Not a good bladder. So this is the anatomy of the patient. So what we did is we first identify the distal rectum, and we decided to leave the distal rectum about 8 centimeters as a neovagina. And our plan was not to touch the actual fistula, because when she's older, we're just gonna do an anterior plasty to enlarge the introitus, but we already will have the bowel inside. So here we had, we left about 8 centimeters as a neovagina. So we transected, that's gonna be our vagina. And then we brought the proximal sigmoid as the neoanus. So this is the vagina. This is what's gonna be brought as the anus. 1 year old. So this is the neovagina, and we are bringing the neoanus. So that's the anus. So here's a drawing so you can understand what we did. That's the bladder. That was the rectoperineal fistula. So we left this portion, the distal portion, as the neovagina. Removed that portion that was the rectum that was still fixed, and we brought more proximal redundant sigmoid as the neoanus. Any questions or comments about this case?
So, and it just something extremely important is that you can do that operation. I'm talking about the operation in which you leave the rectum that attached to the urethra as a neovagina and take a new portion of colon and pull it down as a rectum. We are stealing the rectum to be used as a vagina. That is only indicated when the patient has poor prognosis for bowel control. And that's very important. If you do that operation in a patient with normal sacrum, you will be making an incontinent a patient that will be continent. If this patient had a good sacrum, the patient will be continent by definition. But if the patient has a poor sacrum, then you can steal the rectum to be used as a vagina. Very important that.
So there is a very good question. What's the plan for vaginal dilation? There is no plan for vaginal dilation. This is a young girl. The bowel, I show you the pictures, had excellent blood supply. This will not stricture. This is a good size bowel. What we are gonna do when the girl is old enough that she wants to start her sexual life, we're gonna do a Heineck Mikulicz in the anterior portion. So I'm gonna show you again the anatomy and what we plan to do. So when she's older, what we are gonna do, I don't know if you can see my arrow, but we will do a plasty in the Heineck Mikulix in the anterior portion of what this was a rectoperineal fistula to make the introitus larger. But inside, she has what's going to be a good vagina. She will not require dilations, just at the skin level, because obviously this is not a good size. We don't think babies should undergo vaginal dilations because there is no purpose of trying to dilate, because we're not going to make a good enough size for sexual intercourse in a baby. A baby has a small vagina and she will only need that opening to be adequate size when she's older. I know there are more questions. Why was a small part of the rectum removed? The rectum has a portion that it's fixed, and then the sigmoid is mobile. In her case, in the contrast enema, I don't know if you saw, but there was a sigmoid that was very mobile and that reached the perineum. If I didn't remove that portion, I wouldn't be able to bring the rectum down with good blood supply. When are you going to start bowel management? We start bowel management around 3 years of age. In the United States, the deadline is when kids go to kindergarten. That's when they have to be completely clean for stool. This patient was a patient that suffered from severe constipation. She was actually born in a different hospital. She was admitted for fecal disinfection. So I also think that leaving that rectum hopefully will improve her constipation, but she's currently on laxatives. Just to treat the constipation, she will be on enemas when it's time for her to be completely clean in the underwear for stool. Would the rectum as vaginal vault be too small when the patient is older? No, it was very dilated rectum. We think it's going to be a good size vagina. Just the opening at the skin level is the one that will have to be enlarged. I think I answered all the questions, so we're going to move to the next case, the last case that I'm also presenting. So this is a very straightforward case to finish. This is a male patient with anorectal malformation who underwent colostomy opening and mucus fistula 24 hours after life. He had a normal MRI, no tetracord, no presacral mass, and normal kidney ultrasound. So this is the distal colostogram. I want you to look very carefully because it's very subtle. So look very carefully and you're going to answer the question. What malformation is this? Rectoperineal fistula, rectourethral-bulbar fistula, rectoprostatic fistula, rectobladder neck fistula, no fistula, or I don't know. Everybody can vote. Wow, we have all over the place. So rectoperineal, the one that won was rectourethral-bulbar fistula. And the ones that were honest were the people that said, I don't know. So congratulations to those two groups. Everybody that answered differently. Let's look careful because it's very important to know how to interpret a distal colostogram. First of all, if you are the surgeon, you must be down there with the radiologist doing the study. So we place, can you see my arrow? Can you see, Ray, my arrow?
Yes.
Okay, so we place a radiopaque marker. So ours looks like an error. There is where the anal impression should be. You want to see the sacrum. So here you can see that the bowel is below the sacrum. That's the number one information. Here's the mucus fistula. We're injecting contrast. If you look very careful, you can see a very thin line that goes into the penis. It's very thin, But I was there at the study, so I saw it. And at this point, the baby started being uncomfortable and crying. And I thought I already had the information that I needed, that I had enough bowel, that I was going to find the rectum posterior sagittally, and that I could bring it down as the anus. So I decided to stop the study. But if you look carefully, I hope you can appreciate this line here. It's a very thin line. But at this point, I was confident I was dealing with a rectourethral bulbar fistula. So in a patient with a normal sacrum, if the colon is below the sacrum, this is not a rectal bladder neck fistula. If this was truly no fistula, you would see the bulging closer to the anal marker. In a rectoperineal fistula, you would be seeing contrast extravasation through here. So this is a rectourethral bulbar fistula. So what would be your approach? A laparoscopic assisted PSARP, PSARP only, PSARP and laparotomy, or I don't know. Everybody can vote. And majority said PSARP only, 83%. Congratulations. We feel that in rectourethral bulbar fistula, using laparoscopy is more invasive, and you don't need laparotomy if you have enough bowel length for the pull-through. So we think the PSARP is the ideal operation for those cases. So this is the perineum of the baby. You can see that he has a good anal impression, a good midline groove, well-formed buttocks. So here we are using the stimulator, and you can see the center of the sphincter contracting. So we open posterior sagittally, and we identify the white fascia that represents the posterior rectal wall. Here you can see levator in one side, levator in the other side. And then because we have that distal colostogram, we know that this is the rectum. You put the silk stitches and it comes to you. And then you can open with confidence because you know this is the rectum, and we're going to continue to open in the midline until we actually see the fistula. Fistula was tiny, but we could see with our naked eyes. So here is the fistula, and we have a lacrimal duct probe inserted. And when you insert the lacrimal duct probe, you can feel the Foley catheter right there. So now the next step will be to put multiple 5-0 silk in a hemicircumference above the fistula site. So this is a very important stitch. We put the silk stitch through the fistula. And now we place multiple 5-0 silks above our fistula tract. So here's just showing. And here we dissected the rectum. Here's what the fistula site is. And if we don't have this, it's very hard to identify the fistula site. So now we're starting closure, reconstruction. And this is the anoplasty. And when we finish, if you have a case of good sphincter, good prognosis, the anus should look closed. So that's the end. Do you want to comment?
Beautiful.
Any questions about this case? I'm going to look at the chat. Any questions? So this is a very straightforward case. The way to do it is very calmly, no rush. Well, with like a video of the fistula separation, we actually should make more videos because it's a very delicate portion. But my only tip for that is always clean the lateral walls, dissect the posterior wall, then go a little bit anterior. If it's hard, stop, go back posterior, go back lateral, and then the lateral plane slowly shows you the anterior dissection. But those are very meticulous procedures. You cannot be rushing. You have to do slowly, and you have to be humble. and you have to be thinking the urethra is right there. Can I consider any anterior peaking of the pouch as urinary fistula? I don't know what that. Oh, during the distal colostogram, if you see the beak, I think that's the question. The reality is you have to be there. You have to distend completely. Just having a beak, sometimes the bowel is way lower. So you really have to be there injecting with your own hands to know that you have the anatomy completely and all the information that you need. Let me see if there is any more question. Is it absolutely necessary to ligate the fistula, or we can leave it without suture?
Many surgeons leave the fistula open and they claim that nothing happens. And I believe that's true. So you can leave it with no sutures because sometimes it's even difficult to see the real opening. But we prefer to close it and we play it safe. And we never had a recurrence of a fistula. And if you leave a completely rectal wall, a completely normal rectal wall in front of the fistula side, and you leave a catheter at least for 1 week, preferably 2 weeks, most likely that will heal and the patient will not have a fistula. But if you leave sutures in front of a suture, sutures in the rectum, in front of sutures in the urethra, the patient will develop a fistula.
So the other question is, if you do a PSARP after 1 year of age, is it possible that the fistula closes spontaneously?
No, that doesn't happen. No.
There are fistulas that are so small that sometimes you can't see it. You've seen in the distal colostogram and during the operation, somehow you don't find it. Those are rare events, but it can happen. But the principles of the surgery are the same. You have to find the end of the rectum and you have to separate from the urethra. And with that, you are ligating the fistula. You are curing the patient. What if after PSARP, urine starts coming from the rectum? Do you want to answer?
So if the urine start coming from the rectum, I hope the patient gets a colostomy. And you have to wait at least 3 months and reoperate on the patient. The fistula is not going to close by itself.
Well, I think we answered all the questions. I would like to thank everyone that has joined us. So today we had pediatric surgeons from Brazil, South Africa, Trinidad and Tobago, Nigeria, Saudi Arabia, Egypt, Pakistan, Mexico, Kyrgyzstan, Sudan, Uganda, India, Czech Republic, Philippines, Sri Lanka, Peru, and Colombia, Mozambique, and Honduras. I think Vietnam. I always miss people. You have to type in the beginning, Honduras and Vietnam. So I think I got everyone now, and we look forward to have you in our next meeting. Thailand, Armenia, Iran. Let me see, Thailand. Just trying to catch, because otherwise I publish and then people get upset with me that I missed their country. Armenia. Let me see who else I'm missing. 1 second. Iraq. I hope I got every, oops, there are not. Kosovo. Just trying to catch everyone. 1 second. Bahrain. Ghana. Bahrain. And I think I got everyone. Perfect. Thank you, everybody. And we'll see you next time for our last meeting of the year. Please send cases if you have, so we can share and learn with each other. Bye-bye.